All right, we're on.
Yes, sir.
Okay, everybody, welcome to Journal Club, the last one in July, right? Is today the last Wednesday of the month?
Yes, sir.
All right, so welcome everybody. We are for a change in Newark, first time in Newark in what, 2 or 3 months, and we are back at Monarch next week. Sorry, we are a little bit late. Might be my fault. I'm not sure. We were at the Infusion Center for the state police all morning long. So we have our journal articles. If one more person emails me about the Paramedic 2 trial, which was out this week, I'll freak out, but that's okay. We also started doing like an oldie but a goodie article on our website. So one more time, because I haven't said it recently, if you haven't logged on to our website, www.emsfellowship.com, all the articles are there, and the email list is now going out to 12,000 people every Sunday. So if you have any questions, just give us a shout, and we're certainly willing to take our journal club on the road, like we have been recently 1 or 2 times. So we're just going to get right started since we're running late. Oh, by the way, before I forget, so thanks to everybody who came to our EMS dinner. We had 425 people there, and we are about to announce shortly who will get the money that was donated. So. We'll start with interesting cases. So who is an interesting case?
So I have a pretty good interesting case. So last week I was on my ALS ride along, and I was with the paramedic unit, and initially we had gotten a call for like an elderly female for a chest pain. She had chest pain for a couple days, and we picked her up. We were heading to one of the hospitals. Her vitals were stable. She was hemodynamically stable. Like I said, the chest pain had been ongoing for a couple days. We were on our way to the hospital when we got a call on the radio that said that the nearby BLS unit was bringing in a patient who was actively seizing. They were about the same amount of time away as we were from the hospital that we were going to. And then as we pulled into the hospital, they said that they were actively they were engaging in CPR in their patient. This was like a BLS truck that was kind of rolling into the same hospital that we were with my patient who was hemodynamically stable. So like as they were coming into the hospital, BLS was engaging in CPR, kind of looking in the back of the truck. They're like one provider is providing CPR, and me and the paramedic kind of realizing that or the EMT kind of realizing that they need a little bit of help, kind of rush in over to this unit. You know, I kind of take the airway or start bagging the patient. This is kind of while this is kind of ongoing within the hospital, within the ambulance bay of the hospital that we arrived at. He started providing compressions, and we brought the patient into the resuscitation room. We got her on the monitor. She was in VFib. She was pulseless. So we obviously gave epinephrine. We shocked her because she was in VFib. This was ongoing.
In no particular order, you did that.
No particular order. So this was ongoing. This happened 3 times. She was apneic, or she was having agonal respirations during this course, and the head physician that was running the resuscitation didn't tell me to move, so I subsequently intubated the patient, kind of recognizing that she needed to be intubated. And we went through 2 cycles of shocks because she was in refractory VFib. After the 3rd shock, we realized that it was refractory, so we decided to shock her with double sequence. We got ROSC.
After the first double sequence?
After the first double sequence, she had a pulse. We got an EKG. She had a stent. So
Did the ER physician know about double sequence, or?
Honestly, I don't know.
But he or she, whoever it was, decided to do it, so gave an order for a second defibrillator.
Or just approved it as he seemed like most of the things that we were recommending to do. Give amiodarone, give epinephrine, you want to intubate this patient. Was kind of just agreeing with and kind of just going with the flow, so to speak.
So the paramedic was with you, went into the ER and was helping out.
Correct.
All right. So 3 single shocks didn't work, 1 double sequence and converted and got ROSC.
Got ROSC. EKG showed. I actually didn't take a look at it. I think it was anterior lateral MI, and then I actually just got a text from the paramedic that says that he knows a couple people and found out about the follow-up care about the patient. So the patient went to the cath lab, had 100% occlusion of the LAD, and she's in ICU now, doing pretty well. Expecting it for recovery.
Right, so that's good. So what can we learn from this?
We can relate it to the article that we're going to talk about today about response time and EMS care.
Right. So we all know that we should do double sequence defibrillation after 3 shocks. Of course, when we implemented that protocol, I made that up. When North Carolina did this and published their article, they did it after five single defibrillations. The reason they picked 5 and I picked 3, because we all made up everything we're doing, is that they don't keep a second monitor defibrillator on their paramedic units like we do, right? So they have to rely on their supervisor vehicle coming to the scene and doing a double sequence, whereas we can just take our second defibrillator and do it. Of course, the problem is we have LifePak 15s, which weigh like roughly 35 pounds. So people will argue that, that's 70 pounds at 3 flights of steps. For everybody who theoretically is in cardiac arrest, you get there and they're not, it's a lot of weight. My argument is, well, if you get up 3 flights of steps and then only a second defibrillator and actually in VFib, which is refractory, somebody has to run all the way down and all the way back up, and that takes a little while. But I get it, 70 pounds is not light with all the other equipment. I understand, I don't think it's a good rationale, but I understand what people are saying. All right, so you did 1 double sequence, and the patient went to cath lab. What if the patient didn't have a stem and EKG? Do you want the patient to go to cath lab?
Is there a benefit?
Yeah, so 30% of a culprit lesion, right? 30% of a culprit lesion, and they should belong in the cath lab based upon 30%. But not everybody will universally do that. But people argue, if 30% chance of a culprit lesion, is that worth getting out of bed in the middle of the night? And if you're in a community hospital, maybe it's probably very challenging to do. All right, that's good. Any other interesting cases?
I had one that presented an ethical, interesting situation with an elderly patient from a nursing facility who had recently been admitted, and you're giving me, do I need to talk louder? Am I good? Okay. He had recently been admitted to a hospital nearby and was intubated for what we were told was a COPD exacerbation, and had returned to the nursing home just 2 days earlier, and the call went out for lethargy. And I was actually with Nobbin for this one, and there was a lot of discussion in the back of the rig, like with the medics, about whether or not the patient was DNR or DNI at that point, because he needed to be intubated if he wasn't, and no one could produce any paperwork for him, although some of the nurses indicated verbally that was the case. They had no paperwork, and the patient wasn't wearing any bracelets or anything to indicate that was the case. So we ended up intubating, and then he required some push-dose epi en route to the hospital to keep him hemodynamically stable. And then we got there, and at like maybe 10 minutes or so after we got there, he crumped, and he ended up undergoing CPR. And through the grapevine, I had heard that the family was a little upset that had happened, because somebody signed a DNR somewhere, but no one had any copies of it. So it's just kind of an interesting situation to be in, where you know what's medically right for the patient, but legally you don't have any.
Yeah, and we're presented with that scenario constantly,
Yeah.
right? That's unfortunate. That happens to us all the time. I mean, it happens in the emergency department when somebody is hypoxic, and I remember the patient who came from a little far away to an emergency department I was working in, and she was hypoxic, and the family wasn't close by, and it was either, do I intubate, or is a patient DNR? Do I not, or DNI? Do I not intubate? Do I wait for the family and have her go into cardiac arrest? And people don't realize this happens like all day long, right? Every day. So, I mean, I think there's no right answer. You can get in trouble if you do, you can get in trouble if you don't.
Right.
I guess the answer is get in trouble in the side of intubating if you really can't figure any of this out,
Right.
right?
The other thing is you can't take back not doing anything. So
Right. You can
Right.
easily remove the tube, right?
Yeah.
But you can't.
Right. Plus, the thing is, sometimes I've had family who said, she didn't want to be intubated, but yet when you find her comorbidity, there are none. So I've had patients who had no comorbidity, and their patient's not that old, and they said that she didn't want to be intubated, and that's much different to me than somebody with like metastatic lung CA, who's hypoxic, who is really thin, and they say, well, there's a DNR. Can you just give us a minute to find it? And I'm like, yeah, we'll give you a minute. This story makes sense a little bit to me now, right? But I've had people with like no medical problems, and you just go, and I'm not gonna. you have to show me some documentation.
Right.
So that's why it's good to have like the Pulse form. That's a big thing that's going around the country right now is the Pulse form, and you can talk to your physician about it. Also, a lot of people with DNRs or DNIs, I let them know, especially when they're getting up there where they may actually need it, is you want to put it somewhere on the refrigerator. I say, like, once you open up the front door, just like paste it right on the wall, right on that wall. If there's a wall there, so that people can see it.
Right? Why couldn't they find the form?
The nursing, so they were I think the nursing staff was in a bit of a rush to get patient out of the facility, and it was a little unclear as to how long he had been, having issues breathing. So I think they were nervous
Yeah.
about that. Nobody could locate the physical paperwork, and at that point it had been maybe 10, 15 minutes-ish. And
Yeah.
so we were just like, we can't wait any longer because he wasn't doing
Right, because you
well,
can't sit
so-
unseen forever and wait.
Right.
And my other thought is, not that we can't do all these great things pre-hospitally, but let the hospital take care of some of this stuff with social workers and all these people who can talk to the family, give them support, figure all this stuff out. Because I've had units call me where they're on scene for 30 minutes trying to figure this out with somebody who's about to code, and you just go, we can't sit here on scene. Let's just opt to move the patient. I've also had people where I get called by the family and they're all like screaming, and you can hear them with the paramedics at the scene going, we want my father transported, and my father refuses to go, right? And you're like, I can't take the person against their will, and then you're thinking, is this person hypoxic and altered? And I've been called by paramedics who say, at times when they say the patient's ANO times 3, and the family says this is not their baseline, they're confused. And then usually what I do is I get on the phone with the paramedics and I have a discussion with them, and I try and convince them that, let's make a decision as a group to transport the patient, because if the family's saying that this is not the patient's baseline, that's probably the best evidence we have that this is not the patient's baseline, even though you think the patient looks perfect, sounds perfect neurologically. And then, you also decompress people in that moment by saying, listen, I'm not here to work against you. I want to figure out what's best for your father, and I want to do this. Because I have people say, get on the phone and you say, this is ridiculous, I'm going to call my lawyer, blah, blah, blah. And the first thing I say is, hi, how are you? I'm not I don't want to work against you. I want to figure this out together, right? Because what are we going to do? They're going to get their lawyer on the phone, I'll get my lawyer on the phone, and they're just mad because things aren't going their way, or this is not their vision of how their family's last few minutes would be. But you always try in that 30 seconds to decompress people, and usually you can get it to happen.
And a lot of times the lawyer will agree with us that you can't kidnap them, but then
Right, but then that's the question: what's their baseline mental status? And and when you have no good answer, you can rely on the family. And if there's a big issue with the family and the patient, that's better off figured out in the emergency department. Not like we're taking a unit out of service essentially to stay on scene, and we can't do that. And the question really is, how much do you want to try and deal with a situation on the scene and have a long discussion with the family? Because I've seen people say, let me get a crack at the family. I can try to work it out. And then 20 minutes later, you're like, you're still trying to figure it out. And sometimes it's just better just to err on the side of providing more care and going to the hospital. I brought people sick as can be who were in the peri-intubation period where I thought they probably didn't want to be intubated. I put them on CPAP and just driven to the hospital with very hypoxic people. I think it's the best you can do. It's a compromise, right? And I've always tried to give the staff like a heads up, like this is what's going on. You're about to engage in a very rough family dynamic. Because I think even still today, we as a medical community don't do justice to preparing people for like end of life decisions, right? Some people are really good and some people are really bad at doing this. So what happens in EMS? We get stuck.
I do have to say also that was a very rewarding experience for me overall, even though I know that it didn't end well for the patient. It was nice to be there with the medics in real time when they needed on scene like medical control orders where they would have had to call to get permission to give
Right.
the epi or give their like RSI medications, and we were right there, so it didn't delay anything any further. I think if we had delayed that, he probably wouldn't have made it to the hospital.
Right. Well, we just had a case where like the best decision wasn't made, right, with the end of life issue, didn't we? Remember that case?
Right. So essentially, what happened was
Because we learned from our.
Sure.
This wasn't a mistake, but we this was an opportunity for improvement.
Right. there was a family member. I'm sorry. There was a patient who was sick. It was cardiac arrest. The family was at the bedside. This was an elderly patient, about 96 years old, with cancer and multiple comorbidities, asystolic. BLS had been doing CPR for about 10-15 minutes prior to ALS arrival, and upon their arrival, their assessment was the patient's asystolic and elderly, and downtime really unknown, but the BLS had been there already for 15 minutes. They called control to get a time for pronouncement.
But prior to
Well,
so keep going.
no, I'm sorry. The family was at the bedside as well, and they did not want to do any further resuscitation, and were requesting to stop. They
So
called
like 87,
96.
96,
Yeah.
asystole. ALS gets there and says, no intubation, no IV. Let's not do anything.
Right, and the
Because
family
the
was
family
there.
didn't want anything more done.
Right, and they said this is their wishes, and paramedics were amenable to this, and they felt that was probably the right thing to do in this scenario. So they called control to get orders for a pronouncement. The doctor online basically said, well, you really haven't done anything yet as far as resuscitation, as far as a line, meds, intubation. And there isn't really a DNR form that says that this patient doesn't want to be resuscitated. So I think that you need to resuscitate the patient.
Right. So, opportunity for improvement. So these are things that cause my ulcer to bleed a little bit more every day, right? So the paramedic calls you and says, Jocelyn, let me tell you what your paramedic just did. So what's your response? My response is usually, well, our doctor, right? I changed the narrative. It's our doctor's not, and I'm like, well, right, I feel your pain, right? There's an opportunity for improvement. By the way, you didn't call me or any of my EMS doctors, this was during the day, during the week, right? So that's which we always say we're available. That's an opportunity. You could have gone through dispatch. You could have done like several things. I mean, certainly there were multiple problems. One is you don't need a DNR or a power of attorney. The patient's asystole, right? So it doesn't really matter, right?
Right.
Two is, you don't really, you can just, you don't need like a termination resuscitation effort. The patient's 90 something and asystole, right? You can just do nothing. Like, that's okay. There's no, it's in every state, you can just do nothing. I mean, this patient was 97. If this patient showed up in my emergency department, I'm the person to pronounce the patient without doing anything. And over the years as a resident, people have said to me, Mark, you can't do nothing. You have to at least do something when they're in the emergency department if EMS brings them in. And ever since I was a first-year resident, I never understood that. I said, why? Why can't I just do nothing? Why can't I pronounce them as soon as they get from the paramedic stretcher to my stretcher? Where's the law that says I have to do something, right? And I never but there are people who still believe this stuff, right? That you have to do something. I mean, this is such a no-brainer, right?
Right.
And but listen, somebody calls you, and in that moment, you kind of sometimes panic a little bit, especially in the beginning. Right?
Sure.
So we talked to the doctor, right?
Right.
And I think I was in my car when I got the tape, and I cringed a little bit. But we get these cases in multiple systems, like a lot, right? So the first thing we have to do in real time is get to the doctor as quickly as possible, right? Because invariably they will get the same case in 5 seconds or less, and before the shift ends. So you can't say I'll handle this tomorrow. So we did, right? I mean, I think we got to the doctor pretty quick, and we didn't just say you did the wrong thing. We explained why this wasn't done correctly, right? That's how do you get this person to do the correct thing from now on, and reach out for help.
Right.
So I think, perhaps if there were family members on scene present at the time, this could have been mitigated by a conversation between the physician on the line and the family, and, just
Right.
a little bit of back and forth there where you say, look, what are his wishes? And, at that point you could have made a little bit better of an informed
Right.
decision.
I mean, I agree. You have to trust. I mean, it's dangerous advice to give to doctors as a whole, because some will do great and some will do terrible. And now you have somebody who might do terrible on the tape line with the family, right? So you have to know who your audience is. You have to know who your
Right.
people are. and most systems have so many doctors answering the console who know nothing about EMS, and this is so straightforward to us. What if that doctor had said, I can't pronounce this person in the family, and the voice is raised, and then it gets worse and worse, and this is all taped now, right? So, you have to consider that. That's why we tell people, if it doesn't sound right, just give us a call. Give us a call. But invariably, the first time, the paramedic just said, okay, we'll keep going, right? And then call back, and then the paramedic did the right thing and tried to get like another doctor, right? Which is actually the right thing to do, right? I think the paramedic sent us an email to say, listen, just to let you guys know, I'm not doctor shopping, but this is what's going on. I'm like, great, right? We want to know that you already spoke to somebody else, so we understand what's going on.
They actually spoke to Dr. Parrish, and
The second time.
and his actual monologue with the medics was actually really good. And really what he basically asked was, do you feel that there's any malicious intent from the family, or do you feel the intents are true, and do you agree with that there's benefit in terminating this resuscitation? And that's the right way to take it. It's just saying, first, do you agree with your assessment, and then second, do you believe that the family's being benevolent, and that's fair.
Right.
One quick thing. So, like, if you take that and you kind of flip it on its head and think about the other side of the coin, I remember I received a call about a very young kid, about a 24, 25-year-old, who he was in a traumatic arrest, and the arrest was ongoing for about. It wasn't a substantial amount of time. It was about 10 minutes or so.
It was 24.
He was a young kid.
So 24 blunt traumatic arrest.
Blunt traumatic arrest, and I pretty much have the same conversation with all the medics that I'm on the phone with. Well, how do you feel like the patient's doing right now? Do you think that it would be beneficial to terminate efforts? And I had a little bit of a tough time kind of hemming and hawing and thinking about what the right thing to do was with this kid who was a blunt traumatic arrest. I wasn't able to see the patient. The paramedics were insisting that efforts were kind of futile, and even after 10 minutes, I was just having a hesitancy to call it, and I didn't know if I should say to continue efforts or
Right.
continue trying.
So the person was asystole,
Patient was asystole.
probably from an MVC.
Yes.
So what's the chance of a good outcome for somebody with blunt traumatic arrest who's asystole? Listen, we're just playing Monday morning quarterback here, so our life is easy. You had to be on the front lines. Blunt traumatic arrests, asystole, chance of a good outcome, almost nothing, right? So let's prioritize what we're going to do, right? I can only give you one procedure to do on this 24-year-old blunt traumatic arrest. What's the one procedure you want to do? That you're going to give orders for the paramedics to do. Bilateral needle decompression, right? Doc, I'm going to listen for lung sounds first. What do you say?
No, don't do it. Just
Who cares? If one, you're probably on the roadside. Two, what are you going to do? Tell me there's good lung sounds, and then the patient has no chance of survival for sure. So, just go ahead and do it. Many people have heard good lung sounds on the roadside for blunt traumatic arrest, right? When they don't exist, right? Just decompress both sides of the chest. If the EMS physicians are there, what are we going to do?
Finger thoracostomy.
Finger thoracostomy, right? Put a finger in the hole, right? Just scalpel, hole, keep it open, and hopefully it'll work. So let's say you don't do anything. What do you do now? Let's say nothing happens. You don't get a rush of air. Grab the ultrasound machine, take a look, right? Ultrasound machine, no cardiac activity, done. What if you see cardiac activity at that point? That's a blunt traumatic arrest, and you see cardiac activity. So now hopefully you're saying things like, do I see a big pericardial effusion? Let's say you see a big pericardial effusion.
You could try and drain it if you have your ultrasound, and in theory.
Yeah, I guess you could take a
have-
central line, right, and just do
Yeah.
continuous drainage, right? Or is that the rare patient? And this is a very rare scenario who might benefit from a pre-hospital thoracotomy, maybe, right? You might be able to open up that chest faster than you can run back to the vehicle and get a central line kit to do continuous drainage. But though, everything you're doing for a blunt traumatic arrest, the only thing that tips me over to more doing it is if the person's 24 years old. right? And maybe just went to cardiac arrest in front of you or soon thereafter, right? But you don't. And maybe you're looking for things like a hole in the heart. So you open up the chest, see a hole in the heart. What are you gonna do? And then probably the RV, right? So you see a laceration of the RV. What are you gonna do?
Staple it, Foley.
Staple it, right? Right.
Don't switch.
Oh, probably don't do a Foley. But doing Foley's is probably something everybody was taught in residency. It's really kind of silly. So I was at a dinner, and I was the only guy who wasn't a trauma surgeon. So I was like the smartest one in the room, and so we were talking about this, and people were trained from all over. It was a very smart group. And we were talking about this, and they were all talking about their thoracotomies. Some people had done like 3 thoracotomies the night before, big centers. And I said, do you put in a Foley? And they all start like laughing. And they go, you don't put in Foleys in. I'm like, but this is what's in the textbooks. They go, no. This has been shown to cause endocardial necrosis. You never put a Foley in a hole in the heart. And I go, but this is what we teach. This is what's in the books. And they go, it's all wrong. And none of them, from multiple different places around the country, said they all agree you should never put a Foley in. And that's kind of interesting. So, the bottom line for them is, you staple everything. Staple everything, staple the hole, staple the hole, staple the hole. And they said, the problem is, and I looked it up, I mean, there are a lot of case series about this. You cause necrosis immediately to the endocardium, and you get infarction immediately when you put a Foley in. It's kind of interesting. It's not what we normally teach, but I thought it was interesting. There was a lot of people from a lot of different places all felt that way.
Yeah, I'm just curious how a staple through the endocardium is going to cause necrosis.
Oh, it does. Oh, but it does okay. The staples do okay.
I'm trying to think, like, I think
The staples do okay.
Theoretically, it's less surface area. Than
Yeah, it's
restricted.
yeah, but the Foley and you're blowing up the balloon. You don't,
Yeah, I'm throwing a stitch before.
I stitched right. I mean the problem.
No, I mean, it's
stitching the heart's not easy. Number. Yeah, it is, but we have to agree it takes longer to do that than it does to put a staple in.
Yeah, so I'm just saying, depending on what you have readily available, it's going to take you 5 minutes to find a staple.
And you might need a couple of straight and straight needles are are dangerous.
I'll find
Yeah,
the
one of the
staples a
things,
lot
like,
faster.
well, the first thing I'm thinking of is when we had it in residency, we had it was a traumatic arrest in the OR. Actually, he was shot in the chest, went straight to the OR, and cracked his chest, and just found a giant hole in the left ventricle, pretty much right around the apex. And
No, you mean the right ventricle?
Mhm.
A giant hole in the left ventricle would usually bleed out in seconds.
Well, so he had tamponaded.
You mean
They
he was shot
cut-
this way?
He was stabbed.
It was lucky for him.
Right.
Stabbed right.
So
in
like in most of the federal academies, they teach people if you want to kill somebody, if you want to shoot them to kill them, you go this way, right? Because then you hit the LV, right?
So he was stabbed here, and the ultrasound showed that he had tamponade. So
he tamponade a hole in the LV.
So they took him straight to the
It's a lucky
OR.
guy.
Yeah, so they took him
He
straight
got
to the
there fast
OR.
He
enough.
wasn't.
And yes, they got there fast enough. They take him straight to the OR. As soon as they open the chest, open the pericardium, he obviously codes. So the surgeon pretty much hands me a stitch and says, "Go to town." So
Right.
I was able to stitch it because
And he had a straight needle,
I had a
which is certainly harder and harder to find now that we don't like straight
in
needles,
the OR, they have
especially.
the table. So I mean, thankfully we had a little bit of everything.
Right.
But so that's why the first thing that pops in my mind is that
Right.
particular case. I think it's just because I saw that.
Did you have success suturing it? Because
Yeah.
I had a similar one, and we tried to suture, and we're actually having trouble suturing it. And actually, cardiac surgery, they use these little little pledgets.
Yeah, the pledgets.
They use the pledgets, right.
So pretty much.
And we actually had to take out sutures and put in pledgets because we were having difficulty.
Yeah, so pretty much.
So why do you staple?
Because we were with the trauma surgeon. That's why.
So like essentially
We
we
could've-
just he said just take a big chunk. He goes, I don't really care, it doesn't have to be pretty, he goes, we just want to stop this immediate thing, and he goes, then we can make it pretty around that. Essentially what he did was once we got pretty much threw a figure of 8 in real quick and then tied it off, and then he went back and from kind of top to bottom went with his pretty little stitches
In
and
the
and
OR.
everything else. And again, we were in the OR,
Yeah.
so I think it's a little different. Just the first thing that comes to my mind is that case in terms of stitching, because we had every stitch available. We had cardiac surgery or relatively controlled setting.
Yeah.
So Chris, what do you end up doing with that patient in that call?
I ended up pronouncing after a long conversation with the medic. I was like, "What? So what are your thoughts right now? You're at the scene. Do you think that this patient would benefit from ongoing efforts?" And the medic was like, "No, this patient has a very large head laceration, like almost an obvious like skull deformity, ongoing for 10 minutes. I really don't think that any further efforts going to be beneficial." I was like, "Okay."
So that sounds good. I mean, you always have to think in the back of your head about getting organs or tissue, right? Because you're leaving somebody at the scene, right? For organs, but some organs may not be good. I mean, a patient in cardiac arrest, right? That's the problem with obtaining organs. But to me, traumatic, any type of cardiac arrest and trauma, I all need needle decompressions, no questions asked. When I was a paramedic a long time ago, that was our protocol, right? Traumatic arrest, bilateral. I mean, you guys, was that your protocol?
Yep.
Yeah.
Bilateral darts.
Yeah.
Traumatic arrest, bilateral darts.
Right. I mean, in the old days we used to put two small needles in, but that's another
Right.
story. Right.
Just so I wasn't as thick back then.
Because I have seen this. I have seen a young person. This is one hospital I worked at a while ago. A young person on a road where they didn't decompress the chest. They grabbed him. They brought him in. It was a blunt traumatic arrest. They didn't decompress, and it wasn't done a trauma bay either. They got a post-mortem X-ray just out of curiosity, and he had a big pneumo. And I remember, I can picture that case, and you just go like this. If this doesn't hit home, right? I don't know what does.
Yeah.
But I every now and then I see somebody who like intubated but didn't do needle decompression for like trauma, and you're just like, that's silly. The intubation is not going to help this trauma patient, but the needle decompression might, right?
Right.
And the intubation could theoretically take a small apical pneumo and make it much bigger, right? So it's positive pressure, right? All right, want to jump into the articles?
It goes right into your study.
Oh yeah. We can start with whatever you want.
Go ahead.
Okay, so the article that I had this week was discussing EMS performing simple thoracostomies in the field for traumatic cardiac arrest. Yeah. So
In Houston, what? What?
Yeah.
Right? Did
Yeah.
you know this was going on?
No, I didn't. When was this again? This was not that long ago. 2008. Yeah, I mean the article was just published this year. So, I mean, ultimately the purpose of this article is that a specific EMS group trained their paramedics how to perform a simple thoracostomy, which is what we were referring to as a finger thoracostomy, which is essentially the same thing as putting in a chest tube minus the tube part. And they went through training for it, and after that then they started gathering information about whether or not it was going to make any sort of difference in the field for traumatic arrest. And what they found, so their indications were 70% of the traumatic arrests were blunt trauma and 30% were penetrating trauma. And when they performed the simple thoracostomy, they did get air return on 32% of their patients, and so that indicated to them that there was a high presence of pneumothorax in their traumatic arrest patients. And they did have some survive to leave the hospital neurologically intact, they believe, as a result of their therapy. And so the overall discussion in this article comes to the conclusion that if you have a blunt cardiac arrest, or a traumatic cardiac arrest, and you have pre-hospital providers that are trained in a simple thoracostomy, that it can only improve their chances of making it to the hospital, and it won't worsen them. And they talked about doing like the benefits of this over the needle decompression, which already came up. Size of the patients nowadays a little bit bigger. Traditional like needle decompression might not be sufficient, and so this is an alternative. And I actually thought it was interesting that they talked about placing an ET tube in the chest, similarly to where we would place a chest tube, just to keep it patent.
I mean, it's
Which is
cool,
kind
but
of
it
an
sounds
idea.
strange to me. Well, first of all, why didn't they use their finger? Why did they put a tube in?
I think they were talking about just to keep it open, so it wasn't one other thing that you had to keep monitoring. Because they talk about, like, if your patient if the patient's decompensated after the initial decompression with the finger, that you could go back in and do another 360 sweep with the finger. And so they said if you have, in my mind, what they were getting at was if you had limited personnel, or it was one thing that you didn't want to have to go back and reassess as a potential cause of the arrest, then you could put the tube in there and you know that it would keep the whole patent.
And they started doing this in 2013. Did you know this was going on? The
No.
paramedics are putting in chest tubes in 2013, but they only had 57 cases.
Yeah, only 57.
There's more to this story, right?
Right.
Like they must have had more traumatic arrests, and they must have only allowed certain people to do it.
Right. Well,
And-
yeah, they said they trained. They had. Let's see. How many did they see.
But to use a tube is like suturing it in. It's not that kind of paramedic skill. It's doing all these things that aren't paramedic skills.
And they didn't actually talk about it being sutured in. They
Oh.
just talked about putting it in and leaving it. I don't recall
don't think
reading
they
anything
suture?
about them specifically like suturing it in to hold it in place. I think it was to keep it.
Hey,
Yeah. So they just talk about using a cuffed ET tube to ensure that there's a patent pleural communication, which I guess if you're going to put it in and inflate the cuff and keep it in there, and then when you get to the hospital, somebody could put in a chest tube.
But we don't know that a needle decompression would have been just as good, do we? I mean, I get everything you're saying, but like there's no. I mean, this was retrospective, so that we don't know that if they had picked the right size needles, that they wouldn't have been able to do the same
Right.
thing. Or what about just doing like getting like a big syringe and just pulling back and just doing an air aspiration? Maybe that's just as good. And it's much quicker. I mean, this it's had to take a couple of minutes to do. Like especially early on. Like we think of just a quick scalpel and going in with Kelly's, but that's after doing a bunch of them. It's really quick. After
Right.
in the beginning you're doing everything very slow.
Yeah.
And of course, I mean, is this the group that you're going to help the most? I mean, the group you're going to help the most are people with pneumos, with tension pneumos, right?
Mhm.
These are people in cardiac arrest. And it's interesting.
I guess I
don't know.
could see it because they're now saying too that you can do not necessarily now like just recently, but when I was trained to needle decompress, it was always anterior chest, and now they say that you can also do lateral.
Right.
And so if you're gonna
Well, you probably should always do lateral. I mean, we did a journal club. We did
Right.
who did that?
We just did, I think I represent people.
Was that yours? So we did a clinical pearl about this to say that there's definitely more science behind doing a lateral approach.
But I don't know that that's like been pushed out there yet. But once it does, if you're gonna do that on that side, then why not just take a scalpel and a Kelly and push it in if you don't get good air return? You know what I mean?
Right.
And I think it seems like this study started before we got the new longer needles and thicker needles. You know?
Because because I don't know, in the beginning when you take that Kelly and try and go in the chest, you're timid, right?
Yeah.
Somebody has to stand
Okay.
behind you and say push harder, open up your Kelly, right? So and now I just imagine what if we weren't in back of that person saying that, and somebody was by themselves with a patient on the roadside. They could be trying for a long time, and I know with that needle, you're probably going to be in right away.
Right.
I don't know. I mean, what if the needle? How about doing this if the needle fails?
Sure.
On the other hand, what about like I mean, we're all talking about doing smaller chest tubes nowadays. What about a pigtail catheter like we do? When we do pigtails, and although you're not going to get a lot of blood, their goal wasn't to get a lot of blood; it was just to do air, right?
I feel like a pigtail catheter would take even longer than a finger thoracostomy. Just like with opening up the kit and getting all the pieces in the right order, and then if you're going to use the Seldinger technique,
Right.
that's like an extra step.
I guess I agree with you to the person who's experienced.
Right.
So the person who's not experienced. I mean, don't you remember the first time opening that Kelly, going, I got to be really
Oh,
gentle.
absolutely, right.
And making a big hole. I mean, when they get back Ross, they're in a lot of pain, right? I mean, it's the opening 40 Frenches in everybody that was just kind of silly,
Right.
right? I don't know, Drew, what do you think?
I think they specifically mentioned that there was no paramedic injuries, but this population is probably going to be a population we wouldn't normally see in the ER either. They're going to be probably a sicker, more injured. They may have more chest wall trauma, and they kind of predisposed to having like all these fractured ribs. I can see paramedic injuries being a real concern. Unlike needles, if you're sticking your finger in there and you're sweeping all around, and these are the
Right. I mean,
more,
fractions,
more
not even-
massively
Yeah.
damaged people from trauma.
don't worry about a Kelly. Just take a scalpel, go in, finger behind it, make a hole with your finger, air comes out, and then just take a 4x4 and stick it in the hole and keep the hole open, and you're done. And that's like 5 seconds. You know?
I mean, this is interesting. I mean, I would never do finger sweep 360, especially blunt trauma where you think there's fractures. You're just gonna expose yourself. That's one of the biggest fears that we've always had, right? Is like basically, injuring ourselves with rib fragments.
Especially a
The-
patient with blunt traumatic arrest.
Right, exactly.
Now your risk, the highest risk is to the person doing the procedure.
Yeah, and I mean the bougie assisted maneuvers that they're saying. I mean, this is next level stuff. You could could just potentially just leave the bougie in if you really cared about it. I mean,
That's what I was wondering
You don't
about.
really need it. You don't really
Yeah, why,
need the
yeah,
ET
leave the
tube.
bougie in.
What
I
about
mean,
like
you
a
could
flexible
so,
stylet?
I mean, but
You could do that.
You're
Or, I
gonna
mean,
cause a lot more trauma to the lungs. You can definitely cause more trauma to the lungs
Right.
with those Kellys, you know. And I mean, I think it's a little high risk.
right, but we've all cut the lung parenchyma with a scalpel accidentally, and
Absolutely.
I mean, and you know,
Well-
who cares, right? I mean, I mean, every now and then you put a chest
They have-
tube in,
they have
and the
bigger
lung is
problems.
up, right?
Right.
And then you just made a little dent in the lung, and that's okay, right? That's right.
See, that's why I mean, I agree that I don't think I would put my finger in the chest and sweep, but that's why I liked the idea of the ET tube. Because if you push through, and again, like you're saying, somebody who's experienced to know what they're feeling for, if you pop through, just put your finger there to keep it open and put an ET tube in there, maybe even with a stylet to make sure that it's rigid enough to get in there, then it's in there and you don't have to sweep, you can maybe just rotate the tube on the inside of
Right.
the chest.
Right. And they didn't suture it in. I mean, remember that old teaching that you should be able to lift the patient up by the chest tube? They didn't suture it in the
I
pre-hospital.
don't know that I've ever heard anyone say that.
Really?
Oh yeah,
Yeah.
I remember.
Yeah, like if you don't, you know,
I mean, it makes
the
sense.
should be able to.
the suturing like, but I mean, they didn't suture it in the pre-hospital setting when they're moving the patient. You know, that's kind of, isn't that kind of weird to everybody?
I guess my other thing with like thinking about paramedics being the one to do this is like, how many providers did they have on scene? Because if I was there by myself, I would not stop doing compressions and stop
Do this?
ventilating somebody to do this. So they had to have somebody managing airway, somebody managing circulation, and then they had to have at least one other person in theory.
This is also the time of pit crews, so they would have the first person start CPR, the second person does airway, the third person
Right.
does AED on, fourth.
All survivors were blunt traumatic injuries. All survivors were blunt trauma.
And the ones that made it to neurologic recovery all had initial rhythms of PEA. They didn't mention
Right.
asystole
They probably all had narrow complex PE.
as survived. Yeah.
Right, so they were just had tension pneumos and were just too hypotensive, and that's why they called them PEA. Right?
That's true, yeah.
So they were more like a pseudo EMD, probably. It just shows you the importance of doing decompressing all these lungs for traumatic arrest.
So
I don't know.
what would you personally do if you had a patient who was what I would call a Chicago large, or morbidly obese
Finger.
patient, right? But and you would automatically go for the finger thoracostomy. You wouldn't do
I
a
would-
needle decompression, because I just don't think I've seen a needle big enough on any of the rigs.
Yeah, I mean, listen. If I was with a patient, I had a needle in my hand, and it was going to take me 10 more seconds to get, everything else. I would put the needle in first. No, and then, but I'd always follow the needle with the finger, right? Like always. It's just like if the paramedic puts does needle decompression, we're following it with a chest tube, even if they got it wrong, right? And there was no pneumo, we're following it with a chest tube because we have no idea. But if I could get so the answer is it depends where my scalpel is. If the scalpel's close by, I'm doing a scalpel. If the scalpel's far away, I'll do a needle decompression, and then I'll get the scalpel, right? And then to me, if somebody is entrapped, and I had to do a needle, knowing that I'll have to do multiple needle decompressions, then I'll put a pigtail in. And our pigtail's a little bit bigger than average, so we'll get a little bit of blood, but I'll know that I'm not going to help too much with a hemothorax, obviously.
I've had a time where I had a very morbidly obese patient, and I was using the large needles. It didn't get down there, and you just had to put your body weight to really crush all that subcutaneous tissue out of the way.
Yeah.
I was able to get air and just buy yourself time to then get to the
Sure.
next step.
Right. I mean, and then of course you put the catheter in, and then the patient moves, and now their adipose tissue crushes that catheter, right?
But you probably still get them out of that tension state.
I mean, by and large, I think as physicians we should probably be just not doing really needle decompression usually at all, and finger
Unless there's no
thoracostomy-
scalpel close by.
Right, agreed. But in the scenario where you have an option, you should always go to finger thoracostomy.
Right,
That
and
should
some-
always be your first one.
Yeah, and some paramedics out there have done a couple of needle decompressions, others have done none. So usually I just, if I'm there, I'll take somebody's hand and I'll let them do it, and I'll put my hand on top and I'll just guide them to do the needle decompression. Because we hopefully don't need to do any more needle decompressions. I don't know, so I don't know, would I implement this in an EMS system? Probably not. Anybody would implement this at this point, based upon this article?
Agreed.
Civilian world. Military medics are trained in chest tubes.
Yeah, but they're not the medics that we normally think
No, that's
of.
why I said not the civilian world. Military
Right.
medicine, I think, is a great asset.
I in the military, theoretically, you're on the battlefield for longer, right? So that's
Prolonged
different.
care.
It's more prolonged care.
And they would have a higher need for that based on traumatic injury in the
Right.
field in the military
Right.
overall.
And then, of course, listen, you guys get to a traumatic arrest today, blood traumatic arrest, you should just do, 2-finger thoracostomies, no questions asked, right? It should be straightforward, no questions asked. All right, what article's next? And then after you do that, then intubate the patient with a bronchoscope.
Yes.
So my article was do emergency medical system response times matter for health outcomes, and
So the old article, but a classic.
right, so done in 2011, and the authors were trying to find a correlation or trying to determine whether or not the response times that EMS have any impact on mortality. And the kind of conventional idea is that like you respond to a call sooner, or the faster that you get to a patient, and the improved mortality that the patient might have. And they found that response times do affect mortality, and the response times also increase the likelihood that you're going to that a patient is going to be admitted to a hospital, but response time doesn't seem to be correlated really with the number of procedures that patient really has, like while they're in the ED. So our kind of common knowledge with response times is based on a lot of data with like cardiac arrest, because that's the most easily, I guess, quantifiable kind of response times, right? Patient has cardiac arrest, and you can time everything pretty well. But what these authors wanted to look at, and what they did look at, were things other than cardiac arrests, things like fevers or falls, and really kind of everything other than cardiac arrest, chest pain, kind of those prototypical complaints that are pretty easy to kind of quantify. They didn't really include motor vehicle accidents or anything. But they looked at a lot of patients. They had about 73,000 patients, and they got their patients from this Utah EMS system database. And they said that the reports were from 2001, January of 2001 to December of 2001. And apparently the Utah pre-hospital database is very well organized, and they have times that are very regimented, almost kind of like sounds like they have a run sheet, very similar to the kind of system that we have. So they went back and they looked at these run sheets, and what they found was what they aimed to achieve or aim to find was a response time kind of based on the distance from an agency that's, I guess, very similar to our current system. An agency based on maps, kind of where a patient is located based on their distance from that EMS agency. And I'm going to kind of, they used a bunch of different crazy formulas, which I'm going to solicit AJ for a little bit of his help with kind of these crazy formulas, but they basically found that across pretty much all spectrums, you have an increase in mortality, both 1-day mortality, 2-day mortality, all the way up to a year mortality, based on an increase in the time it takes from the EMS person to get to the patient. And it's to the point of like, you have, I think in one of the variables they had like a 200th percent increase in, or 200th of a percentage point increase from every minute that it takes the EMS personnel to get to their patient, basically. I don't know if that's a valid interpretation of that.
Where is the statistic?
I was getting most of them from Table 3.
3.
Yeah. So Table 3 and Table 6 were the primary ones. But so the authors talk about endogeneity a lot, and they talk about what one of their challenges, or one of the challenges that we have as pre-hospital providers, is that in responding to a call, there's a lot of different outside variables that can really affect how quickly a responder gets to a call, right? Time of day, month, even things that are really hard to quantify, like the urgency in a dispatcher's voice can influence kind of how quickly a provider gets to a call. So they try to account for all of those things, and I think they did an okay job accounting for it. I didn't think that the paper was
paper is extremely multiple regression heavy.
Right.
Yeah, it's very.
What do you mean by that?
They literally just put a bunch of variables into a model and listed them all in a bunch of tables over and over and over again to show you how they're thinking of their concepts, and then pulling that down and giving it to the reader to be like, this is what we looked at and what we kind of found. What I was showing him earlier was when you look at one of these tables, especially table 3, if you take the coefficient value and you divide it by the standard error, you'll find the t-score, and the t-score will allow you to determine if the value is significant. And they do this for you with putting a star next to the ones that are significant, because you'll divide the standard error into coefficient, and if the value is larger than 2.36 ish, it'll be significantly different in the association of
And
mortality.
what do you get? 2.36.
2.36 is I think it's like the 99% confidence in critical value of t, and so it might be 1.96, but it's somewhere around there. I'm just doing the higher margin of the critical value, and every time you look at one of these values in the coefficient table, you're just thinking about the 1 unit change in mortality on distance per change in this. So you can't really interpret it as exact unit of time. You would have to know. It doesn't even actually list the mean, the beta 0 of the regression formula, so you can't actually calculate how much it's changing on average. It's just showing you want this coefficient value to be larger. The larger the coefficient value is, the more it'll have in your change in your mean value. Because all regression is y equals beta 0, which is your mean value, which is going to be your distance on time, plus your all the other values that we have, like 0.0150. So the 1 unit change in that will change our mean value, and that's how you have to think of it when you're interpreting a regression model.
And authors specifically said that on average, a minute increase in response time increases the mortality by between 8 and 17%. That's all the way up to from 1 day mortality to 1 year mortality.
So
The
say
1
that one
unit
more time.
change.
On average, a minute increase in response time increases mortality by between 8 and 17% from 1 day to 1 year mortality.
So I'm trying to figure out how to say this in a lecture. So for every 1 minute response time, additional 1 minute response time, mortality increases by 8 to 17%.
Yeah.
So you better choose where you live carefully, I guess, right?
Yeah.
Or at least in Utah, if no place else.
Yeah.
Are there any? So Utah's mostly rural, no?
I think it was only the Salt Lake City area.
Salt
So
Lake.
it's
Yeah, so it was
So that's
more
more urban.
I mean, I wish they would have compared this to like cost or something. Yes, if I walk around with a surgeon in my pocket, I probably will have better outcomes. But like, where's the balance point?
Right.
And they don't really address that. Yes, if there's an ambulance at my house already, and I need an ambulance, that's better.
Right. So. Right.
But
I
on the
find this hard-
systems level, right? Does having a 3-minute response time or a 15-minute response time change outcomes?
Yeah.
I feel like from a lot of the other stuff we know, it doesn't seem like that's.
It doesn't seem like it
necessarily the
would,
case.
right?
Well, I mean, the variables aren't very well correlated. The R-squared value is low for nearly all of them, and just saying that they're all different from one another. Just saying that the death times are different between 1 day, 2 day, 30 day, 90 day, 1 year. It's not actually saying that they correlate. So this study is kind of weak, is basically what I'm trying to say. And how its prediction ability is really not there.
So
But-
then if I said the statement that Chris just said about
It only infers the population they drew it from.
right.
And I would have to see the data set for why all the values of R-squared are so low. But yeah, they're definitely not correlating in the prediction model. So there is no best model for prediction, because for best models of prediction, you want your R-squared value to be like above 0.8,
Above 0.8.
and like they're all 0.0093. It's just saying they're all significantly different from one another, because that's what the F value states.
So there's no correlation. So what can we say about this study then?
I'm not really sure.
They're just trying to say
yeah.
like that response times significantly affect X or Y. Response times affect
Yeah, they're
mortality.
different from one another.
But I would say that other literature we've looked at says that's very dependent on what's wrong with you. right? And you can't really make a generalization, and you know, so I don't know that I would agree with that generalization if somebody said it to me.
Which one?
You know, that the better response time is, you know, correlates with improved mortality, right? I mean, that's not my interpretation of the literature, but maybe it's true for all comers with all medical problems. But then my next question would be, well, what medical problems, show me a subgroup analysis of what medical problems you're really talking about. You know, sure, for people who are in VFib, all right, I'm on board, maybe. Maybe Salt Lake City doesn't do early defibrillation very well, so maybe I'm on board. But for the average person with chest pain, I doubt it. And I don't know, in Salt Lake City, do they not have BLS who can do albuterol? I mean, I wouldn't have suspected they would have found this either in all comers. Would you guys have?
No, based on what we have read in the past, like we said, based on other studies, I would have expected this.
So all we know is getting there sooner probably does make a difference in general, but it really is a silly number because it makes more sense of what's wrong with the person, right? And we do know that if we put ambulances around regions with more nursing homes, then that's better than if you just put it just geographically around your primary catchment area.
But it's also hard, which it's hard for, what I think the authors tried to account for was, does the severity of the patient's illness have any effect or have any correlation or is anyone related to the patient's response time, but you don't know if those patients are sicker that just happen to live closer to an EMS agency or,
Right.
kind of vice versa. So it's
This is one of those things where I think like the generalization can be misinterpreted.
yeah.
Very easily, yeah.
So like in all comers, sure, maybe it's true in all comers, maybe, I guess,
Yeah,
right?
Because this is like, I feel like you could probably do 6 different stats papers on this. They just really did not narrow down the best fitting model and present it.
And why didn't they? Because don't most people want to get 6 papers out of a data set, not just one?
Yeah, because every table is nearly like a different study, or could go through a different study.
So, but getting there sooner probably is better as a generalization, right? When you don't know when you don't know what's wrong with somebody, getting there sooner probably is better. That's all I'm taking away from this. Okay, who's doing the next one?
On the next one. So, my paper is the plateau point in advanced airway management. So, the study was also done out of Texas, similar to the tube processing study. And data was collected over 4 years to determine what the success plateau point was for advanced airway maneuvers. So, what they tried to find out was at what point another attempt at intubation resulted in less likely to be successful than the attempt before. So they looked at patients, they had a pretty large sample size and looked from 550 different agencies, which is pretty big. And they looked at all age groups and all different types of intubation, so conventional, video, oral tracheal, nasotracheal, and even retrograde intubations. And they looked at basically everyone except patients who just received bag valve masks, and they also excluded any type of surgical airway, so your needle or open cracks, whatever was going on there. And they looked at the success and plateau points, and what they found overall was no matter what type of intubation was performed, and in whatever categories of patients, the magic number, so to say, seemed to be 3 or 4. And after that point, success was unlikely. They also had a couple of other interesting findings here, I thought, and one of them was that over 10% of their supraglottic efforts required more than one attempt. So what we often consider as an easy backup in many circumstances might not be 100% foolproof.
Yeah, I always wonder what's an acceptable missed supraglottic airway in a pre-hospital setting. Or not, miss is probably not a good word. What percent of the time can't get a supraglottic? Because we always see these charts, right, where they compare